Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady, and we are going to do our Q&As, question and answers, and I am joined by Maria, my trusty producer. So hopefully you will be listening in, and if you wrote some questions, you'll hear your question being asked. All right, Maria, let's fire away. What you got for me here?
I love this segment.
I know.
What you have to say, and plus I have my own question that I'll leave for last.
Okay, fire away.
So the first question I have here is from Renee. Texas.
Gotcha. Renee. Texas. What's the question?
What are some important questions to ask my surgeon during my consultation for a revision rhinoplasty? What makes a revision rhinoplasty different and harder than a primary?
Okay, so let's just do a quick dive into all things revision rhinoplasty. So to begin with, the idea of a revision means redoing something, means that someone did a surgery and it didn't go as you had hoped or planned, and now you're seeking someone, maybe the guy who did it the first time or someone else to fix it. Automatically, the surgery is exponentially more difficult when you're revising something than the first time, because naturally there's scar tissue, the anatomy's been disrupted. There is issues regarding blood supply, etc. Of all the surgeries that we do, revising a nose is exponentially more difficult than revising, let's say, a breast. Why is that? Because the primary surgery, the first go-around, is much more difficult than any other surgery. Rhinoplasty is significantly more difficult to do than, say, breast surgery, because the anatomy is more difficult. It's smack dab in your face. We're talking about millimeters rather than centimeters. We're talking about very delicate structures like cartilage and skin. And so as it is, a rhinoplasty is difficult. So now you're going in there to fix something that didn't go right. The nose is very, very unforgiving. The skin scars down, the cartilages become sewn together, the bone ends up having been broken, there's collapse in areas where you can't breathe. And so a revision rhinoplasty is not something you dabble in. So regarding the question, what do I need to ask? The first thing you need to ask is, does my surgeon do revision rhinoplasty? So, well, if they do rhinoplasties, don't they do revision? No. There's a lot of surgeons. First of all, there's a lot of surgeons who just don't do rhinoplasty. Then within the range of surgeons who do rhinoplasty, there's a lot of surgeons who don't do revision rhinoplasty. They choose not to do it. It's just a massive headache. There's a very famous guy in Beverly Hills who won't do his own revisions. He just doesn't want to deal with revisions because you pay your doctor more, right? You pay more for revision, but you couldn't pay them enough for the headache that they're going to own. So there's a saying, you break it, you own it. Or there's another saying, no good deed goes unpunished. So if I do a revision rhinoplasty, I now own that nose. And if it doesn't work out as much as you like, then the old guy, the guy who screwed it up to begin with, is off the hook. So you can see it's not a very desirable surgery to do. How much more could you possibly pay me to make it worth my while? So the people who do it because there's a love for the anatomy and the surgery, and it's sort of, you're committed to rhinoplasty.
And the challenge, I would assume some people like.
Yeah, I mean, you know what I mean. You're a glutton for the challenge and stuff like that. But so the things you want to ask is, A, do you do revisional noses? A lot of them. Do you feel comfortable with them? And more often than not, when you do a revisional rhinoplasty, you need extra material to build the nose, because the normal thing that happens to noses usually is that they start to collapse. The previous surgeon removed too much material, too much cartilage, too much bone. So it is very common on a revisional nose that you need to add structure like cartilage. And the question then is, where the hell do you get it? So when I consent people for a revision rhinoplasty, I'm going to consent them for nose, septal graft, ear graft, rib graft, meaning I'm going to go and get cartilage from those areas, slice it up into small pieces, and insert it into the nose to help build the nose back to have structure. So revision rhinoplasty is not just something you dabble in. And so if you're interested in doing a revision rhinoplasty, you have to make sure the person you're doing it with really feels comfortable. Personally, me as a surgeon, I almost never do a 2-time revision. What that means is that if you are coming to me and you had your nose done 1 time before, it was just the first time you had it done and it went terribly bad, I might consider helping you. But if you had it done once and then revised again, and now you're coming to me for the 3rd time, it's very unlikely I'll operate on you. Not because I don't want to help you, not because I got better things to do, because the likelihood that I feel that I can make you better is so small that that's how people come to you and they're like, I've done it 4 times. Because every time you go in there to fix A, you make a mistake with B. It's just that way. So these are the basic principles of revision rhinoplasty.
Well, speaking of that, I have another question here from TROO.
TROO.
Rhinoplasty 3rd time. So coming from that, so I assume that they're having to get a rhinoplasty for the 3rd time. You'd say what to them?
To me, in my practice, what we do is when you call my practice and say, I want to get my nose done, we treat you like everybody else. When you call my practice and you say you want to have your nose revised, redone, we have you answer a questionnaire before I will see you. I don't want to drag you into my office, pay the consult fee, waste your time, waste my time, so I can take an eye look at you and be like, nope, won't help, can't help you. So in my practice, I would very unlikely be able to help that person. It doesn't mean that no one else will, and it doesn't mean you shouldn't do it. It just means I don't think that there's a high yield or it's fruitful in my practice.
And you said something that a doctor sometimes when they do a rhinoplasty, they might have to do revisions on their own rhinoplasty. Why would that be?
Well, the revision rate, I do 1,000 breast dogs, I'm going to have to fix a certain percentage of them, 1%, 2%, 4%, whatever. It's impossible that you as a surgeon operate and everything you do is perfect. Okay. So the revision rate in noses is the highest revision rate of all the surgeries that plastic surgeons do. So if you operate on your patients, you're going to have to be able to fix some of your own problems.
Right. Got it.
I mean, it's just part of it.
Okay. Cynthia, this is from Cynthia.in.la.
Cynthia.in.la. Mm-hmm.
Right. What is the process for removing implants, including options? When is reconstruction necessary?
So this is a very popular topic. Explantation. We're very, plastic surgery, like everything, is at the mercy of trends. And the current trend is removing breast implants. The reason people are removing breast implants is entities called BII, breast implant illness. I feel like my implants are making me sick. Whether that's true or not is yet to be determined. Next, I'm over it. They're too big. I don't want them anymore. I've decided to go holistic, whatever the case is. So there is a big trend towards removing implants. The big issue with removing implants is not can I remove them. I can remove them in 12 minutes. Incision, remove. The question that you need to ask yourself is, will I be okay with the way they look once they're removed? So when you remove an implant, you are removing volume. And without that volume, you're going to be left with whatever you have. When a patient has an implant removed and they have a decent amount of breast tissue of their own, you can usually do something with the residual breast tissue to do a lift or rearrangement so that leftover breast tissue, albeit smaller, looks pretty. But if you are 90% breast implant, right? You're super skinny, you're an A cup, your breasts are mostly implant. You remove the implant, you got nothing to reconstruct. Reconstruct what? With what? So you're going to have to be okay with having perhaps breasts that are aesthetically not so pleasing. There's a huge trend of, I'll just put fat in there, fat transfer. I have had 10 podcasts about this, so I'm not going to belabor it, but I personally am not a fan of removing, let's say, 300cc implant and then liposuctioning your entire body, creating all kinds of irregularities, and then shoving fat into an area that a lot of it doesn't survive. So in my own practice, I'm not a huge fat transfer guy, predominantly because I don't like the donor site, meaning the area we borrowed from. So that's the whole idea about explant. It's not about whether or not I can remove it. It's a matter of what my breast will look like without it.
Well, that's my question, because I had a breast, I had implants done 15 years ago, but now I gained weight. So I'm like a double D, and these implants are like 100 cc's.
So you are the perfect candidate to do an explant because your implant is relatively small. You have a lot of breast tissue of your own. Do a lift/reduction and be left with smaller, pretty breasts and no implant. That's the kind of case that I advocate for. Let's remove them. Yeah. Not when you're predominantly implant and you're left with just bags, paper bags, and now you want to do something magical. That's just not going to work.
Every time I get a mammogram, they always tell me, "And why did you get implants?"
Yeah, that was 20 years ago. So
yeah, well, not 20, but 15. Okay, so I have the next question is here from, speaking about breast implants, Calliope.Marin.
Calliope.Marin, okay.
Gummy versus silicone implants. I thought it was...
So it is and it isn't, and it's just this nomenclature. So implants are divided into two types. That's it. Saline, silicone. Saline implants are silicone bags filled with water. They're a bag, an empty balloon made out of silicone filled with saline. Silicone implants are the same exact balloon, silicone, filled with silicone and capped. So they're essentially the same implant except for what's filled inside of them. Okay? When you are talking about gel implants, the silicone ones, it talks about how soft or firm the gel is. When the gel is super soft, it has the advantage of feeling like it's exactly like your own breast tissue. It's soft. You can't even tell where it is. The disadvantage is that it has ripples and irregularities. It's like a soft pillow. It has waves in it. As the gel becomes thicker and thicker and thicker and thicker to the point that it becomes solid, it's then called gummy. The reason the term gummy came to exist is it's just a descriptive term. It's not a scientific term. It comes from gummy bears. Gummy bears, if you cut them in half, they don't leak out juices. They're sticky, firm sugar candies. And if you cut a gummy bear implant in half, it doesn't leak, but it's also firm. Now, the true gummy bear implants, the ones that were shaped, were removed off the market because they were textured. So now the only type of silicone implants we have are round implants. The manufacturers really like the name gummy because patients really like the name gummy, and so are still using the term to reflect or represent the most firm version of it. But it's not a true gummy the way it used to be. So it's just kind of marketing, in my opinion.
Okay, so I have here a question from BB in Miami.
BB in Miami.
Does insurance cover breast reduction if deemed medically necessary? Why would it be deemed medically necessary?
So breast reductions and certain other plastic surgeries potentially can be coverable by your insurance, assuming the following items. Number one, your insurance has it as a coverable procedure. In other words, your insurance, the one you have, your husband has, your family has, considers the thing you want to get done as a procedure that they cover. Secondly, if it is like your eyelid skin or your breast, it needs to be considered medically necessary rather than cosmetic. So they have their own criteria for each procedure, and medically necessary means that it's causing me a medical condition. So with breasts that are large, if they're so large that they're causing you back pain, neck pain, you get a rash underneath your breast, you have, herniated a disc in your neck, etc., you can then go to your doctor. That doctor can then submit it. Then your insurance, based on your coverage, can determine whether or not it's coverable or not. So that is something that you can determine for yourself. The second question is, will your doctor accept your insurance? So question number one is will the insurance pay for it? The second question is, will your doctor accept your insurance? The answer is that the overwhelming majority of high-end, highly qualified, excellent surgeons will not accept your insurance. Well, why the hell not? Because your insurance will pay shit. So a breast reduction often pays like $1,500 or something crazy to do a reduction. You pay $1,500 for some filler or some minor procedure. Why on earth would somebody who's going to spend 4 or 5 hours accept that insurance payment? They won't, nor should they. So the question is whether or not it is coverable, and the second is whether or not your surgeon will accept it. Those are your two hurdles.
Got it. This question also about breast implants is from Annette Marie. Saline versus silicone, what is a better option?
So there's no better option. There are different options. So saline has, I would say, few benefits, but in my opinion, mostly not so many benefits. And silicone has a few more benefits. So what are the distinctions? A saline implant is essentially a glorified water balloon. It's a balloon filled with water. So when you go to squeeze it, it will feel firm, much firmer than a gel or silicone implant. When you go to hug somebody that has saline implants, you will feel the implant come across against your chest. Silicone is smushy, so it will not be as obvious. Because it's firmer, the rippling, the irregularities, can sometimes be more palpable with your finger. Like if you run your fingers against the chest, you might feel them a little bit more. The advantage of the saline implant, it's arguable as its advantage or not, is that if it were to rupture, if it were to burst, you will know immediately because it will deflate. Like you'll be in the Bahamas and all of a sudden you'll get up one morning and be like, oh shit, my right breast is completely gone. It deflated. It's saline. It's water. It just goes away. So you'll have one normal breast and one deflated breast. The advantage of that is that now you know. The disadvantage is that now you're screwed because it's emergent. Like you can't go walk around with one normal breast. Silicone implants usually are what's called a silent rupture. If they burst, you don't know it because the silicone doesn't evaporate. It's still there. It just kind of stays in the pocket. And after a period of time, either through your mammogram or your MRI or something like that, you'll come to notice that it's there. And then you'll remove it. In my opinion, and my personal preference for patients, I feel like the silicone implant is a far superior prosthesis than the saline implant. I consider the saline implant a tricycle, and I consider a silicone implant a motorcycle in terms of their development.
Well, I think we need to go on a break.
Okay.
When we come back, we're going to talk about the dreaded liposuction that you love.
Oh, dun, dun, dun. All right, let's take a break and we'll be back with the rest of your questions and some answers. All right, welcome back to the second half of Plastic Surgery Uncensored. We're doing your questions and answers as always. And Maria, tell me what the next question in line is.
Well, this one is more of a comment. I wanted to start off with this. Comes from Sally B.
Sally B. All right, what'd Sally B say? I hope it's good.
I saw your liposuction post on Instagram and TikTok. Excellent post and truly appreciate your honesty and educational information. So.
Oh, okay, that's nice. I like that. That's cool.
How has been the reaction to that post in general?
So it's interesting because I didn't, I post shit all the time, right?
Mm-hmm.
I've been posting for years. I never really had anything go so ballistic and viral. And like we posted it on TikTok, which I'm barely on. And there was like 500,000 views. There's 26,000 likes. The post was as follows. I simply gave a cautionary alert about my philosophy regarding liposuction. In the era of BBL and fat transfer, in the era of BBLs, Brazilian butt lifts, and fat transfer in general, borrowing from one area and sticking it somewhere else, whether it's your face, your breast, or your butt. My philosophy is that doctors across the globe are being way too aggressive with liposuction because previously the goal was to fix an area. Now the goal is to get as much fat as you can so that you can fix another area. And my post,
like the
butt or whatever, my post, which got a lot more, Jesus Christ, traffic and reaction than I had anticipated, was that you are going to guaranteeably have outcomes from the liposuction that you had not anticipated. And what are they? Some loose skin, some irregularities, some dents, some rippling, and some divots. AKA, the area we liposuctioned will not be smooth and tight. The end. And I posted it, and you should see hundreds of patients were like, oh my God, I can't believe that happened to me too. I wish I'd known. Holy shit. Like hundreds of women and men, but mostly women, about how they did this liposuction years ago and now they regret it. I'm just talking as if I opened up the floodgates on like the Me Too movement. Then I had a handful of people, some patients, right? That's not true. I did it and it was the best thing ever. High five. I'm so happy for you. And then I didn't realize I got a lot of doctors that were pissed. And I'm thinking to myself, what the F? Get off my page. What's it to you? And they're trying to turn it around. This is funny. And make it sound as though I was being irresponsible and scaring patients. Listen how petrified they were that they would lose patients, that they came onto my page and tried to rebuttal me, that me telling patients to be careful was reckless, and that they insinuated the reason was because I'm not a good surgeon. I mean, my God.
Fighting words.
Well, I replied, all right. All right. You know, one thing is I'm not shy, and I'm not going to back down regarding a statement I made, no less to my own followers. So did I say you shouldn't do it? Did I say it's illegal? No, I said you need to be damn careful. And then it follows by hundreds of testimonials of people saying he's right. So I never thought it would get this much attention, and especially not by so many plastic surgeons. And well, what can I tell you? It's the #1 procedure done in the world. So you shouldn't be surprised.
Well, speaking of liposuction, I have a question here from Annette A. And she says, of the small percent of people you do lipo on, what criteria makes them a good candidate?
That's a great question. I didn't say I don't do liposuction. I say I do it seldom, and I do it selectively, and I do it conservatively. So the question is excellent. So when you do it, which is infrequent, what are your criteria? #1, the amount of fat I will remove will be limited. I am not doing liposuction to suck out all the fat from a given area. I'm doing it to improve the contour a little bit, because if I remove more fat, you will end up having more complications. It's not a matter of doing less doesn't get a complication. It's just not as obvious. #2, I only do it if you have thick ass skin, high quality, thick skin. Why? Because once I remove the fat, we are at the mercy of your skin to sit smoothly and not come shriveled up and loose. So example, I've had 3 children. I have had 3 births. My belly is nice and loose and has fat in it. Will you lipo my lower pooch? No, I will not lipo your lower pooch. You have a shit ton of loose skin there. And if I remove that fat that you have there by lipo, not by tummy tuck, you will look terrible. So you need to do conservative lipo, and you need to do it in areas that have solid, thick skin. That's my criteria, case by case.
That's good. Okay, I have here, and I'm not sure what the question is necessarily, but it says Riza Danayan says, being stressed the night before surgery. I don't know if she's saying, is it common to be stressed the night before surgery, or
all right? Well,
if you're stressed?
I have my philosophies. So I have a lot of patients who ask me if I will give them Xanax for the night before surgery.
Really?
Yeah, all the time. I would say like not 10%, 15%. Hey, Dr. Bond, I know I'm going to be a wreck the night before. Can you give me a Xanax? And my answer is every single time the answer is no. Because I don't want to operate on someone who is so anxious that it's unmanageable without drugs. The answer is cancel your surgery. So listen carefully. Every single human being on the planet who has a surgery, cosmetic or not, will be anxious. There's no such thing as having a bunionectomy or a hernia fixed or a hysterectomy or a breast augmentation and not being stressed. That means you're not on planet Earth and you're not paying attention. The difference is plastic surgery is elective. You pay a lot of money to do this to yourself because you are so excited that this is going to be good for me. I am taking money out of my kid's college account if I need this. So if you need this and you are excited about it and you're going into surgery and you're so anxious that I got to drug your ass, then you're not ready for surgery. You're not ready. We haven't explained it to you, or you're not a right candidate. You cannot do elective surgery with that much anxiety. So I don't want to drug anyone in order to do surgery. You need to be stressed, but stressed to the extent that you can manage it like every other person. So it's philosophically, the answer is no, you can't. So yes, you will be stressed, and no, I won't give you drugs.
That's good. I think it's normal to be anxious, especially when there are always consequences to these.
Yeah, of course. Right, of course.
There's always a risk factor. This one's an easy question, I think, from Jessica Lee Younger.
Mm-hmm.
Jessica Lee Younger.
Okay.
What's best scar recovery, cream or serum?
Okay, so I'm going to make a plug for my scar management podcast, which is extensive, but I will give you a short answer here. 99% of scar management post-operative stuff is bullshit. Let me repeat it in case you didn't hear me. 99% of the stuff that is sold to help your scar after surgery is bullshit. How can I say that, Dr. Raban? Because if it worked, it would not be a secret. Every surgeon in the world, a hernia doctor, your OBGYN, your ENT, every plastic surgeon, everyone has scars and everyone wants them to go away because no one wants to hear it from their patients. So imagine there was this magic cream. And when you rub that magic cream on your scar, the scar goes away. Do you think it would be some secret? Or do you think it would be on Amazon, Walgreens, CVS, every doctor and every specialty would be giving it to you? It's bullshit. 99% of your scar is the following two items. You and me. 50% of that is you. What will you make? What is your DNA? What are you predisposed to do? Are you going to make a brown scar? Are you going to make a red scar? Are you going to make a white scar? Are you going to make a thin scar, a flat scar, a raised scar, a smooth scar? What will your DNA create? The other half of it is, what the hell is the guy or gal closing me going to do? Who is closing me? How are they closing me? How many stitches? What type of stitches? In what layers? How much tension? Is there glue? Is there staples? Are there stickers, tape? Those are the two components. The part of it, which is you can't change. It just is. It's just you. The part that you can change is the idiot or the expert who closes you. 90% of plastic surgeons don't close their entire wound themselves. Have you ever been to a really busy law firm that doesn't have a paralegal? Have you ever been to a really busy accounting firm that doesn't have bookkeepers? How about a really busy dental practice that doesn't have a hygienist? So it shouldn't come as any kind of shock to you that plastic surgeons have people who help them in the closing phase.
No, now doctors have physician's assistant.
Right. So they have a nurse, a physician assistant, a junior doctor, or even the tech who should never be doing it, helping in some degree, if not doing the whole thing. So the only thing you control is the how it's closed dial. I have for almost 20 years only been the person that closes every damn stitch, every layer. I'm talking compulsive. That doesn't mean you're going to make a great scar. It just means you'll make the best scar that your body will generate. So once that you and I have done our dance, after that, it's hogwash. I have things that I do. We have paper tape, we do massage, we do this, that, but I'm talking max 1% to 2%. If you made a shitty scar, there ain't no laser, no cream, lotion, potion, nothing that's going to make that go away. So that is my philosophy. If not, I could sell a ton of snake oil in my practice.
Okay, now I have the last question.
The last question.
What was the most challenging and longest surgery you have ever had to perform? And that comes from D. Delaware.
So it's hard to say. I can tell you that I do a lot of long cases, more so than most of my colleagues. I do a lot of 7, 8, 9-hour cases, which is brutal. Facelifts, eyelids, brows, tummy tuck, breast lift, breast augmentation, lipo. I do a lot of combination surgery. So they are very long, and they're all challenging, but they're not memorable. For me, I'll change the question, not to the longest or the most challenging, but I will kind of answer the most rewarding or most memorable. This surgery was when I was a resident. I was in training. I was at USC Medical Center in downtown LA. And I was a chief resident, which means I was in my last year. And I was towards the end of my training. So I was about to graduate in the next, 6 months. And I was on call at the main hospital, the USC County Hospital, which is like a major trauma center, just gunshots and all kinds of crazy shit. And I remember, like it was yesterday, it was like 6:30 in the morning and I got a page. That's right. Those were the times with pagers. And the page was, the ER. And I called the pager, called the ER back on my Motorola flip phone. And the lady, the ER doctor, was like, yeah, we have like a 12-year-old girl that was hit by a car. And she developed a scalp avulsion. A scalp avulsion. So what a scalp avulsion means that her hair, this happens a lot in women with ponytails that work in places in factories. The skin of your head, if you notice, if you rub it back and forth, slides. It slides.
It's hurting already thinking about it.
So if you think about it, scalping was a phenomenon of Native American Indians back in the days, and they can take your scalp off because it detaches from the bone. So this young lady was hit by a car, and somehow, I don't know how it happened, but her scalp came off and a part of her ear. So her ear and her scalp came off, and it was detached from her head. Okay? And they had the piece. They had the scalp and the ear connected as one piece. And then they had her as a human on the other. And they called us, and it was me, and I remember who it was. It was Dr. Wally. He was the fellow, which is the year one above me. And it was just the two of us because our chief, the guy that was our supervisor, was not present. We couldn't find him. So me and Deb went to the hospital, and the two of us reimplanted her scalp back on her head with microsurgery. We went under a microscope. We connected the blood vessels, the artery, and the veins. We sewed the thing back on. Then she was obviously asleep. Then we put her in the ICU. Then we used leeches to get the circulation going. And then the damn thing, 95% of it survived. That was my sort of like, hallelujah. I get goosebumps thinking about it.
Have you ever seen her again after that?
No, never again.
And was there a lot of like? I'm trying to envision.
No. The area around her head where it detached, we sewed back on.
And does that hair cover that up? Does hair go back in that area or no?
It depends on where it was cut around. You're asking too many detailed questions. All you need to know is that she has her head. All you need to know is her scalp survived and she's walking around, and hopefully she's married, because at the time she was 12 and it was like, I don't know, 20 years ago.
That's so scary.
Yeah. Well, plastic surgery is cool shit.
Yeah.
All right. That's it. That's your Q&As, guys. All right. Well, that wraps up another episode of Plastic Surgery Uncensored. I hope, as always, you've enjoyed our show. Number one thing I ask at the end of every show is, if you like our show, you love our show, you're like, wow, this was great, do me a favor. Go online, write something nice, leave us a good review. It really makes a difference. It, first of all, makes us feel good. And second of all, it really helps bolster the podcast so that it can continue. Secondly, make sure to download and subscribe, not only yourselves, because you're obviously listening, share this with other people, because again, the more people follow our podcast, the more the information is disseminated, the more useful this all becomes. And as always, we're grateful. We hope that you join us next week. I'm sure whatever we're going to talk about, it will be interesting. And as always, signing off, Dr. Ravon on Plastic Surgery Uncensored.